Hi everyone, this is Dr. Praveen Patil here. Today I am going to speak on topic called spinal anesthesia. The contents of my topics are introduction, indications and contraindications for the spinal anesthesia, and in which position the spinal anesthesia has to be given, that is patient position, and what is the technique, how to administer the spinal anesthesia, and what are the drugs and the complications of spinal anesthesia. So anesthetic agent is introduced by injecting into the cerebrospinal fluid. So cerebrospinal fluid is there in the outer part of the brain as well as in the spine. So where then the injected agent, that is drug, act on the nerve root and exerts its anesthetic action, that is numbing action, on the corresponding nerve. On the which nerve root we are administering the medicine, that corresponding part will become numb. You can see this is a cross section of the spine. So there are three layers, that is dura mater, arachnoid mater and pia mater. So dura mater is the outermost layer. So we are administering the anesthetic agent into subarachnoid space in case of spinal anesthesia. So cerebrospinal fluid is also will be there in the subarachnoid space. In the same area we are administering the medicine. In case of spinal anesthesia, drug injected into subarachnoid space, and spinal anesthesia is also called as subarachnoid block or intrathecal injection. So indications for the spinal anesthesia are so used in surgeries below the level of the umbilicus. Example, surgery of the lower abdomen. Example for the lower abdomen surgery is appendicectomy, and surgeries of the pelvis, surgeries of the inguinal canal, surgery of the inguinal region, and urogenital, anorectal, and lower limb surgeries can be performed under the spinal anesthesia. Then, what are the contraindications where we suppose not to use the spinal anesthesia? Contraindications are divided into absolute contraindications. We suppose not at all use the spinal anesthesia in these conditions. Relative means there are some risk will be there, so we have to calculate, and based on that we have to decide. So absolute contraindications are patient refusal, patient not at all willing to take the spinal anesthesia, and infection at the site of the injection. So we don't want to carry the infection along with our needle into the subarachnoid space, and which may leads into meningitis. So to overcome that problem, we are avoiding the spinal anesthesia. Coagulopathy, any bleeding disorders. So we are causing the trauma on the meningeal layers, and so we don't want any unnecessary bleed inside it. So increased intracranial pressure. So increased pressure in the CSF. So intracranial pressure, that is in the brain. So what happens? There will be more built pressure in the CSF. So we may not be able to seal the meningeal injury at that time, so the CSF may keep on leaking it. So to overcome that problem, the spinal anesthesias are avoided in case of increased ICP. Severe hypovolemia, that is volume is less, that is circulating volume is less than the requirement. So in those conditions the spinal anesthesia has to be avoided, because the spinal anesthesia itself causes some up to some extent of the hypotension. So hypovolemia is already there, means that may worsen the condition, so it has to be avoided. Severe aortic and mitral stenosis. So in these conditions also we have to avoid the spinal anesthesia, and relative contraindications are sepsis, pre-existing neurological deficit. It also depends on the what is the degree of the deficit, and severe spinal deformity, and what degree of the spinal deformity the patient has. Based on that we can say is indicated or not. Next one is patient position. We can administer the spinal anesthesia in three positions. One is sitting position, second one is lateral decubitus position, third one is the prone position. So sitting position and lateral decubitus positions are commonly used positions for to administer the spinal anesthesia drug. So midline is the easily appreciable in sitting position and often used in obese patients. Sitting position is often used in the obese patients. Patients should sit leg extended and elbow resting on the thigh and head flexed. You can see here in this position the legs are extended and his elbows are resting on the pillow or on the thigh also. We can ask the patient to rest his elbows and head should be flexed so that the intraspinatus space should get increased and it will become easy to administer the needle spinal needle into it. Lateral decubitus position. Patient lie on the one side and attaining the fetal position just as that of the fetus. Fetus, how the what is the position of the fetus? That is the head and legs are flexed. So in that position, the patient has to lie down on the lateral side and he has to flex his knee and hip and he has to flex his neck so that the intraspinatus space will increase. Prone positions are very rarely used and used in case of the bottom surgeries like unilateral surgeries where there is no any need of changing the position after giving the spinal anesthesia and so this is very rarely used spinal anesthesia. So what are the approaches? That is the midline approach and paramedial approach. If you administer the needle into exactly in the midline, that is the midline approach. So you can administer the drug by the adjacent area also. Next is technique. How to give the spinal anesthesia. Patient is made to attain the required position as said previously. Any one of the position as I said previously. Then anesthetic agent injection site the anesthetic injection site is painted with antiseptic lotions and wiped properly to prevent the entry of antiseptic lotion into the subarachnoid space which may lead into chemical meningitis because the antiseptic lotion is the irritant one. So if you take that agent into subarachnoid space through your tip of the needle, so that may cause the chemical meningitis. After that, draping is has to be done. An imaginary line is drawn at the highest point of the both the iliac crest, which is called Tuffier's line. Usually it crosses L4 and L5 interspace. You can see here in this figure. So it's a tougher line. You the either side I have marked the higher border or highest border of the iliac crest and I have drawn a line which is intersecting the midline and that intersection position will be around at the L4 and L5 lumbar 4 and lumbar 5 interspace. So this is called Tuffier's line and that is the point where the Tuffier's lines intersect the midline. That is the point where we have to administer the spinal anesthesia, that is in the intervertebral space. And this is a site of inserting the needle in the midline approach and needle is inserted crossing the skin. If initially it crosses the skin and afterwards it will enter into subcutaneous tissue and afterwards into the intraspinatus ligament and ligamentum flavum and arachnoid membrane. So while passing the needle through the skin, intraspinatus and ligamentum flavum, there will be some up to some extent resistance we face which can be appreciable by while inserting and once it crosses the flavum ligamentum flavum there will be a sudden loss of resistance which indicate that the tip of the needle has entered into the subarachnoid space. Once the tip of the needle enters into the subarachnoid space then cerebrospinal fluid starts coming out. Once it's confirmed that the needle tip in the subarachnoid space, then drug is to be administered into it. You can see which is shown in diagrammatically. So this is 26th gauge needle, one of the thinnest needle of the spinal anesthesia. So it's a 3.5-inch length. It has crossed the skin, interspinatus, ligament and ligamentum flavum and arachnoid membrane. The tip, it is in the subarachnoid space. This is the tip of the needle, and you can see there is a leak, means the flow of the cerebrospinal fluid through the needle. So once it is confirmed, then we have to administer the medicine into it. And what kind of medicines we may use? Based on the gravity of the medicine, these are classified into hyperbaric, isobaric, and hypobaric drugs. Hyperbaric anesthetic drugs are commonly used drugs. Hyperbaricity achieved by adding the dextrose into it, and hypobaricity by adding the normal saline. In head up position, means the head is in the upper side, the hyperbaric drug settles down. If it is hypobaric, it moves towards the cephalic, and vice versa. In the head down position, hyperbaric moves towards the cephalic and hypobaric moves towards the lower end of the body. That is, based on this understanding this, so we can decide the, after giving the anesthesia, which anesthesia we are using and up to what level, up to what extent we need the anesthesia, and based on that we can decide the patient position soon after the administration of the medicine. So you can see here, this is a bupivacaine, one of the spinal anesthesia medicine. So it's a 5 mg here, and dextrose anhydrous dextrose, it is a 80 mg here. So it's a hyperbaric injection. So what are the complications of spinal anesthesia? High neural block, cardiac arrest, total spinal anesthesia, backache, post-dural puncture headache, meningitis, neurological injuries, etc. are the complications of spinal anesthesia. My dear friends, this is a medical educational video. So through this video, I am not training anyone, and this is not for self medical treatment. So thank you. Thanks for watching my video.